My topic of discussion today is on full endoscopic lumbar interbody fusion. So, all of us know that lumbar fusion surgeries are one of the most commonly performed spinal surgeries right now in the entire world, and the number is increasing. One of the reasons for that is the increase in the aging population. And we all know that MIS TLIF is right now the present gold standard and has certain advantages over the open conventional TLIF surgeries, which we all know. But it also has its own set of complications. Praveen Mummaneni, in his one of his papers, he has honed down to certain complications, and these are four in number. The first one is nerve root related complications or dural tears. The second one is end plate violation because of damage to the end plate by the end plate shavers or other interbody tools. Vascular injury here, especially when there is a rupture of the anterior longitudinal ligament, we can injure the great vessels. And lastly, pseudoarthrosis. Either it is because of inadequate disc removal and disc preparation or too little bone graft. And if you neglect the first complication and you look at all the other three complications, all these three complications can be attributed to poor non-visualized end plate preparation. This is another paper by Chun on lumbar pseudoarthrosis. He has mentioned incidence of pseudoarthrosis after lumbar fusion surgeries is almost up to 35%, and the risk factors for fusion failures are all these. And if you look at the lower two ones, the severe osteoporosis and the in-plate management, these are the ones which we have to particularly look for, and these are the ones which can contribute to cage subsidence and cage migration. So when we talk about cage subsidence and cage migration, we have to understand that we have to have a very delicate balance while preparing the end plates. The end plate preparation should neither be too aggressive nor it should be too conservative. And the cartilaginous end plate must be removed while preserving the bony end plate. And visualized insertion of the cages can avoid damage to the bony end plates. Are all the benefits which are offered by full endoscopic disc space preparation. It's a real trump card. It offers direct visualization of the disc space. There is a delicate separation of the cartilage from the bony plate, especially in osteoporotic patients. And the entry annulus is also visualized, which can prevent catastrophic complications. So the indications of full endoscopic lumbar interbody fusion are the same like any other MIS or open TLIF surgeries, and the objective is to achieve adequate decompression, get a good fusion by preparing a good fusion bed and adequate bone grafts, and restore the sagittal alignment of the spine by distraction compression techniques and placing the cage more anteriorly. So there are three approach possibilities right now: the trans-cambian approach or the transformal approach, which I call it as a first generation; the interlaminar approach, which is similar to the conventional harms technique; and the transfacet approach, which I feel is the right now the best approach to do fusions in with an endoscope. So if you look at trans-cambian approach, it is something which causes indirect decompression like an olive. So whenever there is not much of posterior compression with the hypertrophic flavum or subarticular stenosis, this is the approach which I would prefer to go in. And the rest of the tools can cause direct decompression of the neural structures. So what is transformal approach? I think it is one of the oldest fusion techniques described right in the 1980s, and one of the pioneers in that is Said Usman. And it is a facet sparing technique. It does not cut the bone. It goes through the Camden's triangle. Very least invasive, can be performed under local anesthesia, can be done with a very small endoscope, 4 mm working channel. And it, as I told you before, it works on the principle of indirect decompression. So personally, I feel that it is more suitable for thoracic spine surgeries or upper lumbar spine surgeries. The indications are a good disc height and soft stenosis. And the poor indications, according to me, which I feel is a central or lateral recess stenosis and a very collapsed disc space. So these are the disadvantage: high risk of ENR injury, exiting nerve root injury, especially in a collapsed disc space, severe foraminal stenosis. Almost 25 to 30% of the cases may suffer from some kind of neural symptoms post-operatively, and direct neural decompression is not possible with this technique. It is difficult to insert large size cages, and you cannot harvest local bone graft, and The best way is to avoid complication is you can use neuromonitoring in such cases. The second generation is the interlaminar approach, which I feel is the conventional original harms approach, which was discussed before, where you go from the interlaminar space. You don't have to cut the entire facet, just make adequate space of the for the lateral to the traversing nerve root so that the endoscope can be inserted and the cage can be inserted through it. Done under general anesthesia, we usually use a very large endoscope, 5.6 millimeter working channel, and as I told you, the entire facet need not be removed. So according to me, I think it is more suitable for a lower lumbar spine, especially L5S1, where you don't have to cut the entire facet and get away with it. But there is a certain disadvantage because adequate space is not created. There is a chance of traversing nerve root injury in such cases. The facet approach, which is something which I prefer to do, it is done under general anesthesia. We use a larger endoscope. You directly land on the facet. The entire facet is removed, both the superior IAP and the SAP, and it can offer both ipsilateral and contralateral decompression. And one of the advantages of this is you can insert a larger size case, so and least chance of neural injury is possible with this technique. So here are a few cases. Grade 1 listhesis, mild stenosis, there is bilateral foraminal decompression and a mobile listhesis. So I've done a trans facet approach in this case. The first step is always decompression. You land on the facet. This is the facet joint which you can see, and once that is visible, you separate it out from the rest of the things. This is the osteotome being used to cut the bone. You create space. This is the resection of the superior lamina. I keep resecting laterally towards the pars. This is the pars which is being cut with a Kerrison punch. You see that I have not used any drill in this case, just to preserve as much bone as possible so that it can be used for bone grafting. So that was the entire facet which was being removed. This is the hypertrophied flavum to visualize the exiting and the traversing nerve root. That's the traversing nerve root. That's the disc space. You just rotate the working channel and there you land directly on the disc space. The second phase is that of end plate preparation. So it is similar to what we do in open surgery. I use an osteotome to cut the annulus, a box-like cut. These are different specialized instruments which I've made, and they can be used to curate the end plates, the cartilaginous end plate of the bony end plates. And this is the anterior margin of the vertebra. Here you can see. So everything is done under direct visualization. Special curates, that's the anterior annulus. You can see, just you don't have to take a CM photo for this to identify where you are located. You can just see the difference of the tissue, and you can directly note that we have come close to the anterior annulus. So this is very safe in avoiding damage to the anterior annulus, especially in very in the cases of infections where there is very thin anterior annulus. So these are the specialized instruments which I have made, and the third stage is that of cage insertion. So when we are putting the cage inside, first thing I use is this half cannula which I put outside the working channel under direct vision. I rotate it so that the traversing nerve root is retracted and kept retracted by this, and then you directly insert the cage under direct visualization. So this is the final placement of the cage, the traversing nerve root and the exiting nerve root on the right side here. So this is how I use an osteotome to resect the lamina and the facet. I use single hand to hold the endoscope, the working channel and the osteotome, and the right hand to use the hammer. And this is the insertion of the bone grafts in the front of the disc space before I insert the cage. I use a funnel to insert the bone grafts. Placement of the trial disc spacer and final placement of the cages and the screws. So this is the resected pars which has been resected as en bloc while cutting the facet joint, and this is the final incision. Post-operative x-rays, good alignment, good sagittal alignment and well-placed implants. Another case, grade 1 listed with severe stenosis, bilateral foraminal stenosis there. Again, I have done an interlamina approach in this interlamina endo TLIF. This is the cutting of the superior lamina till I reach the free edge of the superior flavum. This is the cutting of the inferior lamina. This is the separation of the ligamentum flavum from the opposite side, opposite lamina. I always try to remove it as a single piece en bloc. There's the single piece, and that's the dural sac. There's the traversing nerve root. You can see a disc fragment there, compressing the traversing nerve root, which I've removed. And this is the cut in the annulus. Again, osteotome is used to separate the cartilaginous end plate from the bony end plate under direct vision. So you see there is no direct damage to the bony end plate, and this is especially very useful in osteoporotic patients where if you use very sharp end plate shavers blindly, in that case there is damage to the bony end plate and subsidence of the cages post-operatively. So this is the final well-placed cage which is seen. This is the amount of bone graft which you get, from doing the laminectomy and the facetectomy with an osteotome. So you see, I have never used any drill here, and these are the post-operative images. Another case, grade 2 listhesis with rigid central stenosis. The technique is slightly different in this case. My motto in doing endoscopic surgeries, I always like to think like an open surgeon and try to implement the technique by use of an endoscope. So here what I do is I put the opposite screws first, the opposite side screws first. Then I decompress, I do a complete annular release and a complete discectomy so that the listhesis becomes a little bit mobile. Then you insert the connecting rod on the opposite side. Tighten the distal rod first, and then gradually using that reduction screw mechanism, I tighten the proximal screws so that the reduction happens. And many times I use a guide wireless pedicle screw insertion like this. So I just use a pedicle probe under image and feel it, and you can directly see it in this video. So that's the the pedicle probe. The ball probe is able to palpate all the walls, so very useful in osteoporotic patients which have fragile pedicle walls. And this is the final insertion of the screws. So advantages of this guide wireless pedicle screw insertion is very less radiation. I can probe for the pedicle walls. For the breach, it avoids the problems of guide wire like migration and bending and that stuff. And you can use conventional open reduction screws. And I feel that it's better in osteoporotic patients. So this is the reduction. This is the insertion of the rod before reduction, then final tightening, which has caused reduction. Then I distract, and then I insert the trial spacer there. And this is again the amount of bone graft which is there, and the cage filled with bone grafts again. And this is the final placement of the cage. You can see that reduction has been completely achieved with a good sagittal alignment. So there is a difference between reduction protocol for spondylolisthesis. For low grade, I always do a decompression first and insert the cage followed by pedicle screws. Whereas in high grade, after decompression and preparation of the end plate and the disc space, I try to reduce with the use of the reduction mechanism of the MIS screws on the opposite side. Then I insert the cage. I usually avoid inserting the cage before the reduction is achieved because that makes the whole thing very immobile. What about degenerative scoliosis? This is a case of degenerative scoliosis at L23 and L34 with severe subarticular stenosis on the left side. What I've done is I've done a selective interbody fusion at 2 levels. So I'll just skip this video for the lack of time. And this is the insertion of the cages. And these are the post-operative X-rays. You can see that there is a good sagittal and a coronal alignment as compared to the pre-operative cases. So we use the endoscope portal for the insertion of the distal screws. So 6 tab incisions, and we can do a 2-level TLIF. So can this technique be used for degenerative scoliosis deformity correction? Now, right now, presently, the anterior to psoas approach, the OLIF approach, is the gold standard for degenerative scoliosis deformity correction, which involves the approach anterior to the psoas. Secondly, we have the XLIF, which is trans psoas, and Lastly, I think this is something which is new, is the posterior to the SWOS approach, which is the PTP approach. So the limitations of OLIF approach or the ATP approach is we cannot achieve direct neural decompression in this case. A second approach is needed for that. It has got limited indications. Doing it in L5S1 is not everybody's ball game. It is only for the experienced surgeons, and it has got comparatively higher complication rate because there are nerves, peritoneal structures, and vessels lying everywhere, anteriorly, and it is relatively more expensive. Whereas if you look at this transfacet approach, you look at the size of the cambium triangle. So what happens once you remove the facet, the size of the cambium triangle really becomes very, very big. So it is possible for us to insert larger size cases. So these are the advantages of transfacet approach. A direct neural decompression is possible. It's a single approach. The anatomy is simple. The cambium triangle is safe, devoid of all complicated neurovascular structures, and it is faster, and more importantly it is cheaper. So why ATP if PTP is better? PTP means the true posterior to SWOS approach, not the prone transverse approach which most of the olive guys do. And the portal is lying there. We just need technological advancements to access it. The technological advancements which we need right now is the better instrument for faster end-plate preparation because we have to do multi-level cases. Secondly, better fusion devices, expandable cages. Now these expandable cages, they should not expand only height-wise, they should expand the size-wise also. They should expand in both the directions. And one of the problems with MIS instrumentation, which I feel, is they fail in causing effective compression and distraction, techniques as compared to the open section. So there has to be some changes in the MIS screws and instrumentation, and we need to find alternatives for autographs for better fusion rate. So limitations of endofusion, I think it's a steep learning curve. It is not recommended right now for high-grade listhesis or severe deformity. The reason is the bony releases are a little bit challenging and more time-consuming. Secondly, the MIS instrumentation is still not perfected, as I told you, to cause effective reduction of high-grade listhesis. Multi-level fixations are again too time consuming. It is not possible right now to insert very large footprint cases like olive cages, but we need to modify them, and we are in the process of that. And revision fusion surgeries might be difficult with endoscopic surgeries. So the key point to remember is it is a safe and effective technique. It offers trifold benefits of elimination, magnification, and a clear field of vision. Low surgical footprint and visualized end-plate preparation is something which hallmarks this particular technique. So the less chances of cage subsidence and migration and pseudoarthrosis, especially in osteoporotic patients, which is right now the current challenge in modern spine surgery. And transfacet approach, I think, is the safest, and it allows insertion of large footprint cages as compared to the conventional smaller cages, but not as big as the olive cages, and probably it may play a role in the management of degenerative scoliosis. Thank you very much.